Hi, good afternoon, everyone. I'm just going to give everybody a few more minutes to, or a few more seconds, I meant to say, to log in here before I get started. You can see people are still joining. All right, so why don't we get started? So my name's Tricia D'Agostino. I'm a partner at Margolis Bloom D'Agostino. We're an elder law special needs and estate planning firm, and we are very glad to have Jennifer Pilcher here today. Jennifer has her doctorate in gerontology. She's a care manager at Clear Guidance, is the firm that she owns. She's a care manager, which is a huge resource to any individual who's looking for assistance with trying to figure out and navigate care for an individual who has dementia or Alzheimer's, cognitive impairment. She's a huge resource to our firm and our clients, and I think you will find her presentation today really helpful. She's going to talk about addressing dementia and identifying it, and ways and how to evaluate and approach suspected cognitive impairment. So I'm going to turn it over to her to go ahead and educate us for the next 45 minutes or so. She is going to take questions. If you could hold those till you could put them in the chat, the question box actually versus the chat. And we'll take a look at those at the end. So you can put them in throw, but we're going to try to hold them till the end. And hopefully we can get to everything. So I will turn it over to you, Jennifer.
Thank you so much, Tricia. I really appreciate the opportunity to be here. And thank you for having me today to talk about this very important topic. I developed this presentation as a response to the increasing number of questions I'm getting from both fellow professionals and family members about how to address a concern about potential cognitive impairment or dementia. At Clear Guidance, we talk a lot about the imagery of the compass as a symbol of the way we help families navigate the challenges of caring for someone with dementia. Many of you on this call, whether you are a professional or a family member, may be the first person to notice cognitive changes in a person you work or live with. In this case, you will be the one to begin to chart the course of how this is identified, discussed, and evaluated. For that reason, starting with the image of the compass feels appropriate for this discussion as well. Today, I'm here to share with you the best ways to go about starting the conversation and the journey of evaluating cognitive health. Many people ask me, how did I get into this kind of work? This woman right here has been my inspiration. This is my grandmother, Caroline, who was diagnosed with young onset Alzheimer's disease in her late 50s. This is a picture of us together when I was about 2 before she was diagnosed. This is a picture taken shortly before she was diagnosed with her caregiver, my grandfather, David. David was devoted to Caroline. However, this being the 1980s, the resources and supports were scarce. They fell victim to all the common pitfalls. They became isolated as family and friends did not know how to address her symptoms. They hired the housekeeper to become a caregiver who eventually stole most of the family silver. David refused to place Caroline in a nursing home, so he carried her from room to room as their house could not accommodate a wheelchair. Unfortunately, he predeceased her in large part due to the stress of caregiving. Although this story is more than 30 years old, and there are much better resources and supports now, the themes and challenges remain the same. Watching their story unfold, I knew there had to be a better way to do this, and I wanted to be part of creating it and making the journey at least a little bit less painful. Unfortunately, this is not where my personal story ends. Many years later, my Aunt Joni was also diagnosed in her 50s. This is a picture of the two of us shortly after her diagnosis. So what this means for me is that working with people with dementia and their families is both a personal experience as well as a career-long professional passion. In order to address how you should go about discussing dementia with your clients, there is some contextual information I want to give you that will help you understand the background of my suggestions. I wanted to start today by talking about how to tell the difference between normal aging and dementia. What should we expect as people age? Certainly, there are changes that occur in the brain that are related to the normal aging process. For example, as you age, it can take longer to encode, store, and retrieve information. The way that you learn is slower than it is when you're younger, and there's need for more repetition. There may be changes in both long and short-term memory changes. And as any of us who have crossed over the 50-year mark know, word finding gets more difficult. Abstraction and mental flexibility can also decline. However, what we do know is that wisdom and creativity continue until the end of life. Dementia is not a disease itself. It's a syndrome or a description of a collection of symptoms. These symptoms are above and beyond what we would expect to see in a normal aging process. These symptoms can include confusion, short-term memory loss, poor judgment, difficulties with language and word finding, visual spatial reasoning, and changes in mood, including paranoia, suspicion, depression, anxiety, and agitation. The most important distinction between normal aging and dementia are two things. One, most people with cognitive changes related to normal aging are able to use compensatory strategies, such as making lists or using a calendar to manage the changes. For people with dementia, on the other hand, they are less likely to be able to use these strategies independently, and most importantly, the changes they are experiencing are interfering with their ability to function in regular life, having a serious impact on their lifestyle. An example I like to use is not knowing someone's name is memory loss. Dementia is not being sure of their relationship to you. Normal aging is having trouble coming up with the word pen. Dementia is not being sure what it is used for. These are extreme examples, but it gives you a sense of what I'm talking about. The most common cause of dementia, and the one most people are familiar with, is Alzheimer's disease. As you can see here, Alzheimer's alone can make up 70% of dementia cases. As you see on the left graphic here, Alzheimer's disease systematically shrinks and destroys many areas of the brain. The cortex shrivels up, the ventricles grow larger, and the hippocampus shrinks, which is a key area of the brain that allows us to store memories. However, there are several other diseases that can also cause the symptoms of dementia. This slide gives you a few of the most common names, but there are actually over 20 different variants of these diseases that can cause dementia. Let's take a look at one example. This is a picture of the different imaging on PET scan of a brain affected by Alzheimer's disease and a brain affected by frontotemporal lobe dementia. You can see already that the disease affects very different areas of the brain. You already saw the distinct difference between Alzheimer's and frontotemporal lobe dementia. However, frontotemporal lobe dementia itself is a group of complex disorders. Neurologists can now identify 7 different variants of frontotemporal lobe disorders. Why is it important for me to tell you about all these different variants of dementia? The most important reason is that these diseases all present very differently. If you are going to help your clients or family members identify the warning signs of cognitive decline, you have to know what to look for. Pretty much everyone knows at this point that the first and most prominent symptom of dementia caused by Alzheimer's disease is memory loss. However, the non-Alzheimer dementias have very different initial symptoms that may be overlooked or misinterpreted if you aren't aware of them. As you can see on this chart, the other diseases listed here have initial symptoms that don't include memory loss. People with FTD may appear withdrawn, experience personality change, or have issues with their language. People with Lewy body disease have hallucinations, sleep disorders, and Parkinsonian-like symptoms. People with Creutzfeldt-Jakob disease may have changes in their mood or gait. People with vascular dementia often have issues with executive function and cognitive slowing, as well as apathy and falling. For many of these atypical dementias, if you didn't know better, you might suspect depression, midlife crisis, or substance abuse. It can be very difficult to get a diagnosis. We often hear from clients that come to us with concerns about their loved one that they're considering a divorce, as it is so difficult to understand and manage their partner's behavior. The other reason that I am bringing these atypical dementias to your attention is that these dementias are more common among younger people. In our practice, we are seeing a significant increase in the number of clients we are serving that have young onset dementia, which means the onset of symptoms before age 65. There's a question about why are we seeing these increases? It could be that detection is better. It could be that the sheer number of people in the young onset category is rising as the baby boomers age. It could be that there is a higher incidence of these diseases. It's also possible that people with young onset are more likely to seek out a care manager due to the complexity of caring for a younger person and the fact that people with young onset dementias often have very difficult behaviors that are difficult to manage. Whatever the reason, it's very important that you have a healthy suspicion of these kinds of symptoms and can help encourage your clients or family members to seek evaluation. There are a series of imaging and other tests, including blood tests, that can now help neurologists to narrow down which diseases we're dealing with. MRI and PET scan are routinely used to identify changes that are not related to normal aging, but also to identify which part of the brain is being affected. A lumbar puncture is now routinely being done to rule out or rule in Alzheimer's disease. These are the exams and tests that are routinely done to look for evidence of Alzheimer's. For the atypical dementias, it's important to look for different things on imaging as well as examine other neurological symptoms the person may be experiencing. I've expanded the prior slide we were looking at that showed the differences in initial symptoms to include what else neurologists are evaluating in making these diagnoses. As you can see, for Alzheimer's disease, other neurologic and neuropsychiatric symptoms are often not present. However, for the atypical dementias, there are other symptoms evaluators are looking for and evaluating. But imaging is only half the process of diagnosing these illnesses. The other way that diagnoses are made is through taking a thorough patient history and extensive interviews with patients, families, or friends. That is combined with a battery of tests that is called neuropsychological testing. Usually, it takes a few multiple-hour sessions to complete. If you suspect your client or family member is experiencing symptoms of dementia, it is vitally important that they have this testing done. Despite the fact that we have these two systems for determining a diagnosis, it can still be quite difficult to get a diagnosis, especially if you are experiencing symptoms of one of the atypical dementias. On this slide, I've given you a graph that summarizes the two major screening tools that are used by primary care physicians or even neurologists at the beginning of the testing process. One is called the Mini Mental Status Exam. The other is called the Montreal Cognitive Assessment. You might be thinking, why is she showing us this slide? I want you to look at the right hand of the slide where it lists what cognitive areas these tests assess. What you don't see on this list is an assessment of judgment, impulse control, personality change, rational thinking, all of which are common signs of atypical dementias, such as frontotemporal lobe disorder. So you can have a client go to the primary care or even the neurologist and have a decent score on one of these tests, but still be experiencing dementia. This is why it may take several visits to the neurologist over 6 months to even 3 years to get what you call a differential diagnosis, which is an educated guess as to which dementia you are dealing with. Why is getting a differential diagnosis important? Because these diseases are so different, they are also treated differently, pharmaceutically and non-pharmaceutically. It is critically important to avoid being treated with something that might exacerbate the symptoms of the disease you're experiencing. It's also important because it helps the caregiver understand what is happening and that the behaviors are not intentional. So now you know how to recognize your client or their family member may have a cognitive impairment. How do you go about talking to the family about what to do next? This can be tricky. First thing to know is that for almost all people with dementia, there is one common symptom, and that is the lack of insight or awareness of their impairment, the severity of their impairment, or how their impairment impacts their life. And this is called anosognosia. For people who have this symptom, it's virtually impossible to have a rational and straightforward conversation with them about their illness or potential illness. In some ways, it's seen as a protective measure for the person with the illness. Without it, we might have a lot more suicide. But for caregivers or those trying to get the person evaluated or more support as they need it, this is really difficult. This is not denial. This is true lack of awareness. If you are seeing potential signs of cognitive impairment, it's very important for you to understand and explain to your clients or family members that they may not be able to acknowledge the illness no matter what you say or how you approach it. Given that lack of insight is an issue for many of these people, how do you go about talking with your clients or family members about how to address the concerns you have or what they are observing? First, we're going to talk about focusing on symptoms. We're going to talk about not using the D word, discussing the importance of ruling out treatable causes, the importance of early detection, and when you should consider a solo conversation with a caregiver. Okay. First, we're going to talk about the D word. First, reassure the client or the family member that many people experience changes in cognition as they age. Second, ask questions. Ask the client or family member to give details about their symptoms or how or if these symptoms are interfering with their daily life. Ask these questions separately to the client and the caregiver and watch for a difference in reports. Whatever you say, don't use the D word, dementia. Talk about symptoms, not labels. Refer to symptoms the person themselves have talked about experiencing. So rather than saying, if you're worried you have dementia, you should see a doctor, you would say, for other clients of mine who have experienced memory loss, cognitive changes, difficulty with attention, etc., I have suggested the following. The key here is to reflect back what they are reporting is the issue without creating more fear about what that might mean. We talked earlier about what can cause dementia. However, there are other illnesses that can cause dementia-like symptoms that are not actually a result of dementia. For example, things like depression, delirium, or even dehydration in extreme cases can cause dementia-like symptoms. When I am speaking to a family or the client about the need for testing, I am often pointing out that it is possible their symptoms are being caused by something that is treatable and that it would be a shame if we didn't know that. This is often something that both clients and their family members can hear and subscribe to. An additional way to think about discussing this issue is to point out the importance of early detection. People often ask me, why is early detection important if there is no effective treatment for these diseases? Two things I want to share with you about early detection. This graph is a good representation of the progression of dementia, at least as much as we know at this point. What we know about these diseases is that there is actually a preclinical phase of the illness where the patient is not experiencing any symptoms. But our detection has gotten better over the years. I am betting that at least some of you in this room have heard about a syndrome called mild cognitive impairment, or MCI. It used to be that we could only detect cognitive impairment when it had reached the dementia stage. We are now able to identify mild cognitive impairment as well. At this point, MCI is still considered its own diagnosis. However, my friend Dr. Vassie at the Boston Center for Memory last week told me that more and more we are discovering that, in fact, MCI is most often a precursor to dementia. So our detection is getting better, and we can recognize the symptoms early on in the disease process. This is important because much of the research about the medications we have available to treat dementia today are believed to be more effective the earlier you receive it in the process of the disease. In fact, there's a common belief among the folks that develop these drugs that they would be effective if they were given in the preclinical stage of the illness. As mentioned earlier in the presentation, often these diagnoses cannot be made until repeat imaging is done to examine the changes in the brain. Unfortunately, we do not have routine MRIs or PET scans for a lot of reasons, so we're unable to detect the disease at this point. Bottom line, the theory is the earlier you detect the symptoms of dementia, the more effective the treatment will be. And that is the message to the client and their family. Early detection is also important because there are things we can do to address both the progression of the illness and the common symptoms. For example, for people who have difficulty with language, we are often recommending interventions with speech-language pathologists who can help with communication strategies. For folks who have Lewy body dementia or Parkinsonian symptoms, we're often looking to PTs and OTs to intervene to help with those physical and motor issues. There are diet and lifestyle changes we can make. There are cognitive strengthening and training programs we can refer people to. There's counseling to help people avoid being socially isolated and having the very common symptoms of depression or anxiety that often come along with this kind of diagnosis. It also gives us time to refer to our friends at Margolis and Bloom to talk about creating documents and adjusting the estate plan now that we know what we're dealing with. Keeping lack of insight in mind, it may be very important for you to have a one-to-one conversation with the well family member to reinforce or introduce ideas you may have mentioned in a group setting. This is important even if the client appears to have insight and be willing to address or evaluate it. You may need to give the family member more information about the reasons for getting a full neuropsych workup to determine if what they are seeing is a result of normal aging or a disease process. It's also important to talk with them about the fact that it will take time to get a differential diagnosis and that they may have to push for more definition over time if symptoms don't resolve. Getting a differential diagnosis can also help the family member understand the symptoms of the illness and allow them to learn strategies for addressing the symptoms. This will allow them to understand the behavior is not intentional and to plan supports accordingly. The last reason it's essential to speak to well family member alone is that they will need to think about supports for themselves as they go through this process. The data on caregiving is not good. As you can see from this example, in this study, 17% of caregivers reported their health was either fair or poor. This is 7 percentage points higher than the general population average. More importantly, 38% of caregivers reported feeling highly stressed due to caregiving responsibilities. Equally as shocking are the number of caregivers that predeceased the person with dementia due to the stress of caregiving, not unlike my own grandfather in the 1980s. Not a lot of that has changed. So, how do you know when to bring in other professionals to help? If the family member is seeking out education about dementia and how to get connected to a neurologist, there are two very important resources here in the Boston area that I would recommend. One is the Alzheimer's Association, and the other one is the MGH Dementia Collaborative, that's at Mass General Hospital. If a client is highly resistant to getting an evaluation or doesn't acknowledge the person, that is a good time for you to get some help. If this person experiencing the symptoms is a younger person, this can be financially devastating and have different implications for disability benefits and the need for Medicaid planning. This is a good time to introduce an elder law attorney that specializes in this area if you do not have the specific information. If there are complicated family dynamics or commingling problems, this is another reason to reach out to a professional. And when the care or supervision of a person with dementia is getting difficult. Of course, my favorite professional to involve is a care manager like myself. And please know that there are care managers all over, not just the state of Massachusetts, but throughout New England and throughout the country that can be helpful to you. And I am certainly happy to connect anybody who needs a connection with a care manager. When do care managers come into this picture and how can they be helpful? A lot of people are unsure when in this process a care manager can be helpful. They can be helpful after receiving a diagnosis or evaluation. At this point, many families feel lost about how to proceed and what to expect. Care managers meet the families we work with where they are in the journey. They can come in at the beginning of a process when you are simply worried about someone and wondering how to have the conversation, or even in a crisis situation. Care managers can help with problem solving, with informed decision making, with giving you tools and strategies for dealing with the symptoms and the behaviors that often come as a part of these diagnoses, and to help you when you're in a crisis situation. For those professionals that are on this call, I want to caution you about making referrals to specific facilities or home care agencies. There are real issues in the industry right now, and things are changing rapidly. Even if you have a family that can only afford a short consultation with a care manager, it can be well worth the money in saving time and aggravation. Placement agencies can be good at locating facilities with certain features and in certain locations, but they do get kickbacks from these facilities and may not be as familiar with overall quality of care. That is a really important place that a care manager can be helpful to professionals in making recommendations to their clients and to you as family members. I will leave you with this so that we can move on to some of your questions. In our practice, we believe that people brave enough to live with dementia or to be a partner to someone who is living with dementia are superheroes. However, no superhero can do it alone. You need a team of sidekicks. We and the folks at Margolis and Bloom are trained to be those sidekicks, to work together with you to support families at every step along the path of facing a dementia or cognitive impairment diagnosis. So at this point, I will open it up to questions. Let me see if I can see them, or is there someone that might read them, or does someone?
Yep, I can. Yep, oh, can you hear me?
Yes.
Hi. I can read. I'm just seeing one right now. Do you think the increase in young onset dementia has anything to do with COVID? I've heard many say they experience brain fog since having had COVID.
Great question. No, I don't. And I'll talk a little bit about the differences. We were seeing huge increases in young onset dementia long before COVID, unfortunately. I would love to think that there is a reason for young onset that's treatable. There is a syndrome that has dementia-like symptoms, really relating more to fatigue and fog, exactly as you have described. There is certainly the case that if someone had a pre-existing cognitive issue and then were experiencing COVID, that it could certainly exacerbate that situation. But I haven't heard any data as of yet that COVID itself will end up being a cause of a progressive disease. So don't forget that young onset is a progressive illness that will get worse over time. And we don't have any evidence of COVID doing that at this time. We don't know. COVID is still relatively new, and it may be that we will learn more later that we'll learn that that is a cause of young onset, but it's not something that that we know about at this moment.
Thanks. I'm also just pulling up a couple questions that came in before the webinar. What steps can people of modest means and lacking long-term care insurance take before disease progresses to locate and access quality care?
Yeah, that's a great question. I'm going to answer it in a couple of different ways. So I think the most important thing you can do to avoid what I would call sort of catastrophic cost is to start thinking early about how you can avoid crisis situations. So what are the most common crisis situations that we see with folks with dementia? Well, one of them, believe it or not, is medication errors. So often people who have dementia are capable of managing their medications, you know, into the progression of the disease and sometimes even into moderate progression. But you really want to be monitoring that closely and looking at whether or not the medications are being taken correctly. A lot of hospitalizations and falls are caused by medication errors. So that's one that really is important to pay attention to. For the atypical dementias that include physical disability like Lewy body dementia or any Alzheimer's with Parkinsonian symptoms or some of the more rare frontotemporal lobe disorders, you really need to be on the lookout for falling. That can really be game changing if someone has a fall and then all of a sudden needs a lot more care than they did before. So I think one of the things is, and then the last thing is safety, right? Making sure that you know where that person is and that they're not going to go out in the middle of a snowstorm. It's all of our worst fear, and not be able to be located. So I think those are, first of all, the way to avoid a catastrophic situation where all of a sudden you need a lot of care. And if you have limited resources, you definitely want to be talking to your local access aging point through the Council on Aging or the Senior Center in your town. They have lots of programs that will supplement some care at home, and that's a really important thing to consider. You also, just by having a little bit of care, or by having intermittent care, you can then avoid some of these other crisis situations. So I always encourage people to do that as soon as they can. Another thing I would say is if you have limited means to pay for care, you need to meet with an elder law attorney to get a consultation on how to prepare for becoming eligible for Mass Health later on that will cover some of the care that you're looking for. So that would be my recommendation.
Okay, and then there's been a few more that a lot more have come in. Can you please talk more about the problems with having a solo conversation with a caregiver without clearly violating a person's autonomy and healthcare decision-making rights? Presumably a person with early stages of dementia are presumed competent and have not been adjudicated incompetent to be autonomous.
So I think there's a big difference between making decisions on behalf of a person and having a conversation. I think that it is important for you to speak to the caregiver alone, to just make sure they're okay, first of all, to make sure they're getting support and to help give them guidance about who they can go to for further support, if it's beyond what you're able to provide for that person. And I don't think we are necessarily violating that person's right to choose, which obviously they have the right to choose and the right to have agency by having this conversation. I think you would do the same thing if you knew that someone you cared about was going through a difficult situation in their lives with a child or with a spouse. You might pull that person aside individually to ask how they were and to offer your support. This is the same kind of a thing. Now, if you were consulting professionals and making decisions for that person without their input while they were still having capacity, then that would be different. And I think that's where the distinction is. But it's an important question, and I think we always want to consider how this is going to feel to the person that is experiencing the disease. But I also just want to harken back to what I presented earlier, which is often the person experiencing the disease may not be aware of it and may not be willing or able to talk about it. And so in some ways, and in many cases, it forces you to have conversations without that person because they're not capable of having them. It's not true of everybody, but it's true of a very high percentage of people that are experiencing these symptoms.
Okay, I have a few that are more financial. So how do caregivers charge for their services? I imagine it depends on what is needed, but could you please provide some typical examples of what clients can expect for costs?
Sure, absolutely. So unfortunately, costs have gone up considerably since COVID. Now a lot of agencies are having to pay for protective equipment. And the other issue that we have is that there's a shortage of people in the industry, both those that work in facilities and those that work in for home care agencies. And so a lot of them have been able to get more money these days, which I actually think is a wonderful thing. But unfortunately, what that means is that increase in cost is then travels down to the consumer. Generally, what we're talking about in the state of Massachusetts, which is what I'll speak to today, is somewhere between $27 an hour up to $35 an hour. That's basically the range we're in now, depending on whether you're looking just for companionship or you're looking for personal care, help with showering, bathing, all of that kind of thing. So you'd probably be on the higher end for that. And then, but there are other options. So that's how much it costs if you hire someone hourly, like per hour. But there are other options for live-in caregivers, particularly if you find yourself in a situation where you need 24-hour care. A live-in is another thing to consider that might be less expensive than having someone there 24 hours a day awake. So that's something to consider. And I think what you want to do when you're choosing an agency is not just look at the cost, but also look at, are they able to give you references of other families that have used their services? Are they, are you able to learn anything about the caregiver before they come, or are you able to choose your caregiver? It's not always the case, but those are important questions to ask.
Okay, and just as a follow-up, do most long-term care policies cover the cost of a care manager?
It's a great question. Many of them do. Not all of them, unfortunately. But if you are thinking of using a care manager, one of the things you should do is have that care manager take a look at your policy. Care managers should be able to read these and give you an answer to that question. If they can't, you might need a different care manager, because that's an important part of our jobs, is being able to pick that out. And a care management agency should also support you in figuring out how to file a claim and how to get the documentation for the work they're doing so it can be covered. So I guess the simple question is sometimes, but the more complicated answer is you should work with your care manager to see what possibilities there are, what areas in your policy there might be that might cover that.
Okay. Do you have suggestions for a family whose mom has dementia but refuses to see a doctor and refuses to move to memory care?
Very tricky. And these are often the scenarios that we're working through in care management. I would say that resistance to care is one of the very top issues that we deal with. I would need to know a lot more about that scenario to give advice. But I think the bottom line is what we're trying to do as care managers is to figure out what that person is motivated to accept, right? So there are medical providers now that will come to your home. And so that might be an option for this person. If it's all medical care that they're resistant to, would they be willing to see a holistic practitioner? So there are a lot of different ways of going about this and creative ideas for how we can get someone to go along with a suggestion. I think agree is sometimes too strong a word, but we want to suggest a scenario that they're going to be willing to cooperate with. And often we're looking for what is their motivation for going along with this, and how can we design the conversation so that we're really going at those motivations. And the same with placement in assisted living. It can be very difficult. It's understandable that folks with dementia want to stay in their homes. And so again, we'd be looking for what's the motivation or what's the situation in which they might be willing to agree or go along with a plan. My best advice is that's a perfect scenario for a care manager, and that's a good call for you to make if you are experiencing that situation.
Okay, and then okay, so someone has a situation where an elderly aunt, age 89, has moved from her home into a senior living facility and is in their memory care section. That's sort of a segregated and locked area, but a very nice apartment and facilities. And this particular facility is called a social model and not a medical model. Can you explain the differences and how to best keep someone in a memory care unit in a social model rather than moving them to a nursing home type facility?
Yeah, this is a great question, and is often an area of a lot of confusion for a lot of people. So assisted living, I'm going to give you the basic on the way assisted living and skilled nursing facilities work. So assisted living is regulated very differently than skilled nursing facilities. So assisted living is regulated by EOEA, which is the Executive Office of Elder Affairs, but it is not regulated the same way that a skilled nursing facility is regulated, that has some federal regulations as well as state regulations. Because of the way assisted living is regulated, there are nurses on staff, but they're not allowed to do any skilled nursing. So they're allowed to do what we call nursing oversight. So they're bringing their skills as a nurse to the position as their background history, but not necessarily as a nurse. Whereas in skilled nursing facilities, nurses can do things like dress wounds and give IVs and do hands-on nursing. So what that means is that assisted living is really what they call, a lot of people refer to as a social model, not a medical model where we're doing treatment, but rather this is a residential social model where people are housed and they have this medical oversight, if you will, or nursing oversight in terms of making sure that your medications are arriving and are in your apartment. And the cues are given by the caregivers, but they don't actually ever touch the medications. They don't order the medications. They have nothing to do with it. So this can be frustrating for families because they feel like, well, if my 90-year-old aunt gets a skin tear, why can't the nurse at the assisted living, put a bandage on it? Instead, what we have to do is call in the visiting nurse to do that, and that gets frustrating. And so there is some frustration, and I hear this a lot from families about why do they have nurses if they can't actually do nursing, which I completely understand. The issue of remaining in assisted living as long as possible is also an issue that we address regularly, and it's understandable that people would want to stay in this residential setting, not just because it's nicer, a nicer place to live, often more pleasing to the eye, but also less medical and more home-like, right? And also less expensive than a nursing home if you're paying privately. So in my experience, many people can stay in assisted living for the remainder of their lives. There are a few exceptions. And so let me tell you what they are and then maybe how you can avoid getting to this point. So one of them is if it takes two people to transfer you from your bed to a wheelchair to toilet, or anything like that. If it takes more than one person to do that, often assisted living will say, this is more than we can do. You need to be in a skilled nursing facility to do that. Similarly, if it requires a Hoyer lift or something like that to get you in and out of bed, that's usually something an assisted living would say should be handled by a skilled nursing facility. Not always. Some assisted livings will do it, not all. If you need something that requires a nurse, like an IV, if you're a diabetic, unfortunately, and you need management monitoring of your blood sugars, that's often a reason people have to go to skilled nursing facilities. That anything medical, if you needed a feeding tube or a breathing tube or a tracheotomy or anything like that, that can only be done in a skilled nursing facility. Other than that, you really should be able to make it work in assisted living. I sometimes hear memory care units saying to me, well, if her behavior is too difficult, or if there are too many falls, then we would shift to skilled nursing. And that is usually a place where I will come in and advocate for a different approach to allow the person to stay in memory care. Because the truth is, people can fall with an aide standing right next to them. They can fall in skilled nursing. They can fall at home. They can fall in assisted living. Falls happen, even when you're as careful as you can be. So I often like to try and work on that with facilities. And then behaviors are really no better managed in skilled nursing than they are in assisted living. So that's another place where I would also want to be advocating for helping the facility to think through that differently. So I think what can you do to try to stay in assisted living as much as possible? Listen to the facility when they tell you they have a concern and address it. Address quickly any issue with mobility or physical health. So if you see any change in gait or balance or anything like that, ask the primary care to order physical therapy or occupational therapy and get that person in there to work with your family member. Pay attention, make sure you've got good medical care around urinary tract infections and the common things that we see people experiencing with dementia, to try to keep their health as good as possible so you don't end up with a major medical situation that would necessitate a skilled nursing facility. So I hope those suggestions are helpful. It's a big topic.
So I think we've actually a little bit out of time now. There's a couple other questions, but I'll send them your way. So if you want to address. So want to say thank you. And Trisha, you want to jump in?
Yeah, sure. Thank you so much, Jennifer. We really appreciate it. This was great. As I said earlier, Jennifer is a huge resource to us and to our clients and to anybody really who's in that situation where you're trying to figure out what the best next step is for somebody with cognitive impairment, which is so many families, you just don't know where to go. So it's always good to check in with a care manager like her to just you can get an assessment to figure out what might be right. Is it assisted living? Is it a nursing home? Or you can just get ongoing help with communication. And so I highly encourage you to reach out if you're in that situation. And Jennifer, thanks again for coming today and spending the time. I know time is valuable and there's not a lot of it. So thank you for taking the time. And if you have follow-up questions, Jennifer's email is here on the last slide. You can reach out to her directly or to us as well. Thanks again for attending, everyone.
Thank you, everyone.